Hello and welcome to StoneSmart Live, everybody. StoneSmart is a Boston Scientific thought leadership program focused on cultivating conversations about your most challenging stone cases. And the StoneSmart Forum is an interactive site on Urology Times where you can view case studies and discuss challenging urology issues with your peers as you all advance the science of endourology. Now, we are here at the 2017 World Congress of Endourology in Vancouver for a live discussion of some of the cases that are featured on stonesmart.urologytimes.com. Well, we're very fortunate to have Dr. Joel Abbott from the Advanced Kidney Stone Program at Chesapeake Urology Associates in Maryland today. Now, Dr. Abbott will preview an interesting case which will be featured in October on the StoneSmart Forum. Welcome, Dr. Abbott.
Thank you so much for having me.
Yeah, it's
Happy
so nice to
here.
have you. So, like many urologists, Dr. Abbott often has patients with larger, more complex stones referred to him. Some cases, like an impacted ureteral calculus, are common, but they are difficult situations to treat. Now, Dr. Abbott showed us some techniques that he uses to approach this clinical challenge, and I'd like to play a section of his video that shows that right now. Is that good?
Certainly.
All right.
Usually, I'll first try to pass, my standard wire. In my practice, my standard go-to wire is the sensor wire, the combination with the hydrophilic tip. I think it's a great go-to wire. And after that, if you're having difficulty without pushing the limits too far, it's advisable to then convert to a hydrophilic wire, such as a zip wire. You can try to pass that up. Sometimes an angle tip or a straight tip wire to just try to find somewhere around that ureteral calculus that the hydrophilic wire will be able to get past. Still, sometimes you're not able to get success with those maneuvers. One thing that I do at that point is I'll bring a open-ended catheter, which I'm usually already have open on the back table. I'll bring that right up to the stone, and I can see that fluoroscopically. And then I usually will mix some lubricating jelly with just a little bit of contrast. So I'll fill that into a 10 ml syringe and inject it right beneath the stone. And then because you have the contrast that's mixed in with the lubricating jelly, you're able to see under fluoroscopic imaging if the stone is moving, or at least if contrast is getting beyond the impacted stone. Sometimes that's enough to just get a little more slippery at the site of impaction to get that wire to pass. One of my go-tos at that point is to use a Segura basket. I think it's a great basket that's underutilized in the ureter. You have to be a little careful with the Segura basket if you're aware it's got a tip, and most people's go-to basket is a zero tip or a nitinol basket, atraumatic with no tip. The Segura does have a tip on the end, and it is a metal basket. It's stainless steel, and therefore it has a greater outward radial force when you open that basket. And so when you open it, it can actually open the walls of the ureter to allow you to then grasp the stone, or at least open it to work at the stone, because a lot of times distal to the stone, the ureter will be collapsing in with inflammatory changes. And then just following that forward, we've seen the end engaging baskets, which I think are phenomenal. The Dakota basket is the one I'm currently using. The end engaging basket is wonderful in that you rarely get a stone trapped in the basket because there is no backside of that basket.
Thank you so much for those helpful tricks on the use of both guide wires and baskets. Now, I have a question for you about guide wires, and that is, what haptic or visual cues do you use to determine when you're safely pushing a wire versus pushing too far? In other words, how do you know when you're potentially in danger of creating a false passage?
So that's a great question, and I address that frequently with my trainees. I always tell them, if it doesn't feel right, it's probably not correct. And things should go very easy. All our maneuvers, we have great instruments, we have good technique. All of our maneuvers should be straightforward, should be easy. And the moment you start having resistance, you're feeling like something might not be right, is the moment you should, stop and reconsider, where the placement of that wire is and where it might be going. So
visually, you're constantly using fluoroscopy as demonstrated in the video. And so you get an idea as to the path and the course of that ureter. And so you would expect that your wire is going to follow that same trajectory and same path. So for instance, in this video where you had this stone, and you could see it was right at the UPJ in that situation. And so you would expect if the wire were to get past the stone into the collecting system, it's going to deviate laterally. And if you're advancing it up and it feels funny, and then you start seeing it advance straight up and not make that curve that you would expect to see based on your fluoroscopic imaging, then you need to have caution there and then reevaluate where you are. So how you would reevaluate is leaving that wire in place. You want to advance up an open-ended catheter, some type of berm catheter that you can inject through and see fluoroscopically where you're at. And if it looks like you're within the collecting system and drainage system, you're in a good place. You know, if you're seeing anything that looks abnormal or weird, you're probably through a false passage and outside of the drainage system.
Right, that sounds like great advice. When do you switch from your go-to sensor hydrophilic tip wire to another option like a hydrophilic wire or an angled wire?
Good question. So before every case, we have on the back table, in my cases, I have a sensor wire open, straight sensor, and I have an open-ended catheter. So those are my go-tos from the start. If I have difficulty where I'm seeing the sensor wire buckle, it's not going up smoothly, and then, as I said in the video, I'll advance up an open-ended catheter to the point where that wire is not doing what I want it to do. I'm having some difficulty. So then I advance the open-ended over top of the sensor wire, and then I'm able to inject contrast. I can inject some lubricating jelly. I can, evaluate what's going on with the ureter there. And at that point, based on what I see, I might, switch over to a hydrophilic wire. And what I mean by that is if I can see that some contrast is going, say, deviating laterally, then I might take an angle tip wire and try to follow that same path, that fluoroscopically is demonstrating where the contrast is going. And then, a lot of times I'll just start off, if I don't see that, I'll just try a straight hydrophilic wire to just see if it can slip past the stone, and a lot of times it will. That's the purpose of the wire, but it needs a little bit of rigidity, so I almost always utilize that through the open-ended catheter just to give it that rigidity from behind. And then if I'm beyond the point where I'm not having success cystoscopically, then I'll convert to a ureteroscope and put a ureteroscope up. The caution there is that without having a safety wire in place ahead of time, you don't want to just jump into doing ureteroscopy. So that's something that you have to do very cautiously, and understanding that you're going up the ureter without a wire in place, and your goal is to put a wire in place. So some people, if they're not comfortable at that point, they'll abort the case. If you're comfortable going up without a safety wire, you can go up ureteroscopically. I would usually use a rigid ureteroscope in the ureter, and then I can endoscopically evaluate, space around the stone or a tortuous path of the ureter or a stricture, and find the odds. And at that point, I might use an angle tip wire, because I can visually see, hey, the lumen is at 11 o'clock. I need to use an angle tip wire and, direct it in that direction. So that's when I use the hydrophilics more.
Okay, that sounds right. Can you elaborate on the technique that you use with the open-ended catheter right up against the stone? What's the ratio of lubricating jelly to contrast that you use?
Okay, so again, if the wire's not doing what I want it to do, it's buckling, it's having abnormal movement, then I leave it in place. I pass up the open-ended catheter. So now I'm somewhere just distal to that impaction, that stricture, that stone. And at first I'll try to, see what's going on again by injecting some contrast. And if I feel that there's a stone there, as there was in the video, then I want to have some upward force and see if I can just kind of push it. So I'll mix on the back table lubricating jelly. And lubricating jelly in itself is very difficult to inject or pass through a small 5 French open-ended catheter. So you need to dilute it. So initially, when I started doing this, I would just use saline or water just to dilute it down so it's still thick enough to possibly, push or advance the stone, but you're not able to see what you're doing fluoroscopically. So that's when I started using contrast as the medium for diluting it, just so that when I inject, I'm able to see, is there contrast getting beyond the impaction site, or sometimes you can actually see the stone just pop out of the site of impaction, and then the collecting system fill up. And it's when I have a trainee with me and that happens, they're always like, whoa,
yeah,
the stone just popped out and we saw it. But it just gives a little bit more that liquids can't do in terms of force to manipulate the stone. So I don't have a straightforward set concentration. I basically just dilute it a little bit, and as you're sucking it into the syringe, if it's not coming, you just dilute it a little bit more, and then enough to get it into the syringe, because the tip of the syringe is about 5 or 6 French, so that's what you're going to be injecting it through.
Okay, that sounds great. So what factors do you consider when deciding whether to use a grasper type basket like Dakota, a stainless steel basket like Segura, or a nitinol basket like Zero Tip?
So I'm pretty specific about when I use which baskets, and my decisions typically where the wall of the urothelium is. Meaning, if I'm in the ureter, the walls are around me to the side, and so I want to use that to my advantage. I want to trap the stone against the wall to grasp it with the basket. So if I go up alongside of the stone and open the basket, and it's a typical pumpkin shape or round basket, it's going to utilize the wall around it to grasp it to the side. You're basically working to the side of the basket, because those pumpkin shaped baskets, they all come together on the back side, so you can't physically grab a stone unless you're working alongside the stone. Now, if you're up in the kidney, it's different, because most of the time you're going to have a calyx and a stone sitting in front of the calyx. So you want to, again, use the wall to your advantage and reach out and grab the stone in front of you. And that's when I use an open face Dakota basket, because it allows me to work in front of me and utilize the wall that's behind me, as opposed to in the ureter where I'm trying to utilize the wall on the side of me. And so I need to work through the side of the baskets.
Right. And speaking about stainless steel baskets and metal baskets, how do you ensure safety?
So it's back to what we said earlier, which is if it's not going easy, it's probably going wrong.
A lot of intuition, right?
But most of the time with the baskets, you just really want to get good visualization. So you're going to be deploying the baskets through a ureteroscope. You want to have, good visualization, your water, irrigation fluid running. If you're not having good visualization to see where that basket's going, especially the Segura, because it does have that stainless steel tip, which people that are used to using the zero tip baskets, which is a very atraumatic basket, they can push that tip into places it shouldn't go, or creating false passages. And back to your last question in terms of when I utilize which baskets, the Segura I think is nice. Again, I use that more in the ureter, almost exclusively in the ureter, but it provides that radial force that you don't have with the zero tip basket, because it's a stainless steel basket. And so in a situation where you've got a little bit of space around a stone and you're just trying to stretch that ureter and create some space, or if you can use the tip of the ureteroscope to kind of headbutt and push the stone a little bit more proximal to a more dilated area of the ureter, but it's still not enough for working room to get that stone grasped. At that point, I would utilize a Segura basket just to create space. It's also useful if you don't have a stone, but you have a stricture that you're trying to incise, and you have the ability to either use a dual channel ureteroscope or running 2 instruments through a single channel. You can have the Segura basket open, providing that radial force at the stricture site, and then use a laser fiber to incise. And the benefit there is, we all incise strictures, and if you're able to have that basket deployed, it's giving you that tension. Which, basic surgical techniques, it's traction, counter traction. So we're creating traction and counter traction within the ureter while you incise, and it gives you a more open finish when you're trying to open a stricture site.
Thank you so much, Dr. Abbott. That was really interesting and very thoughtful and insightful. And thanks to all of you for joining us. Now, Dr. Abbott's full video reveals many more clinical considerations that we just didn't have time for here today. But as I mentioned earlier, it will be featured in October on the StoneSmart Forum. so you can view the full case and join the online discussion then. Just go to stonesmart.urologytimes.com. And to learn more about Boston Scientific's portfolio of solutions for your most challenging stone cases, go to bostonscientific.com/StoneSmart.